My question is for Dr. Bruce in terms of the young ages of onset and the predominance of diffuse type gastric cancers. This seems like it would be really important to offer germline genetic testing for genetic susceptibility to cancer in this population.
And can you hear me on this microphone? Yeah, and we're trying to do that. They've actually done that for 2 of the cases that I know of so far. We're trying to investigate these cases intensively. I know that they've done that for 2 and they haven't found anything abnormal in terms of genetic testing. And we're right now trying to, we've written a very quick protocol to allow us to go in and gather all the information we can, all the tissue samples, everything, to try to learn about these cases. So that's in process right now, and I'll let you know how that goes. Yeah, it was very shocking to us.
Yes.
Hi. This is a question for Dr. Bruce as well. I believe there are 5 under the age of 18 non-CDH1 mutation germline patients at CHLA that you may want, I don't know if you're aware of. They were between the ages of 12 and 16. So you may want to connect and figure out. So they did the germline testing and it was negative. But the patients presented with stage 4 disease, and I don't know if anyone's here from Los Angeles CHLA connections, but they called around some of the physicians taking care of gastric cancer patients to make us aware that this was happening. And so this is the first time I hear that you have a group of 4 patients, so maybe you can connect and figure out.
That would be great. We'd definitely be interested in that. Yeah, and all these young teenage kids were Alaska Native kids. They were all in locales that were completely different. There are no epidemiologic links whatsoever. There's no, so we're getting some information already, but it's being collected right now.
Yeah, I don't know the ethnic background of the children that passed, but we can probably find that information.
Yeah. Okay. Thank you. Yeah, I'd love to hear more from that group. Yeah.
So I'm going to read a question from Yuri Ladabaum. He's the director of the GI Cancer Prevention Program here. It says, so this is directed toward Constanza, but the whole panel as well. The data suggests that gastric cancer, at least for women, is increasing among young people. This looks strikingly similar to data for colon and rectal cancer, where rates are also increasing among young people after the year 1950. Do you think there's some common link here, obesity, diet, processed food, or could it just be coincidence? Should we be looking for a common factor?
Yes, we believe that there is a common cause between stomach and colorectal cancer. We believe that it could be associated with a disruption in the microbiome, an autoimmune component. In the stomach, it's easy because we see the locations are, the location of the tumors is the corpus where the parietal cells are, and these are mainly women, and we know that autoimmune diseases are more common in women. In colorectal cancer, it's a little more difficult. There is one paper from a German group showing that there are autoantibodies associated with colorectal cancer risk. So yes, I think that there is a commonality there. With Chinhur, we are trying to do a study to see if there are, because the counts are very low, these are still rare cases. Just to see if there is a cluster between stomach and colorectal cancer in the US, just to propose potentially a case control study for both colorectal and stomach. Thank you for the question.
It's a really excellent group of talks, so thank you very much. I had a question actually for Fernando with the modeling study that you did. Really, really great. The main question that I had was with the sensitivity testing, since we know that at least for non-molecular methods which aren't widely available or used, that would have to be through endoscopy and culturing. So did you account for that cost, and then also the availability of endoscopy for sensitivity testing?
Yeah, thanks. That's a great question. So I did account for the cost and use the cost for the Mexican NCI, what it typically costs in Mexico City. But I did not account for the capacity. So I would say there would be an issue of capacity given the high rates of positivity. So I didn't account for that. We just like cost effectiveness in general, like how feasible would it be to implement it? It's a different story, but thank you, that's a great question.
Can I just follow up on that? I had a similar question. What did it look like if you just assumed everybody was clarithromycin resistant and just treated everyone saying the resistance is high enough that we're just going to use alternative therapies? What happened to the model then?
Well, I haven't tried that scenario, but it also depends on, let's say if we have a high resistance on clarithromycin and you don't want to use that, but that also depends on the resistance on the alternative strategy, which, I mean, here, like, we call it clarithromycin, but we can just change the label and then use, say, well, metronidazole or whichever, and then simulate. But if you treat everyone with the antibiotic, the projections of the model, which I didn't show, is like resistance will go up the roof very, very quickly.
So this question is for Dr. Bruce. Do you see in Alaska, and you may have covered this, and I may have missed it, a similar transplant effects? So non-native Alaskans that have moved into Alaska, or are they at higher risk for gastric cancer, as similar to what Americans move into Japan or Korea?
We haven't, it's a great question. We haven't really done any extensive studies on that. The closest thing we had was we looked at a cohort of essentially Caucasian teachers teachers will be embedded into the villages, and we assume that then teachers are living under the same conditions that people in the villages are living, and so they would have the same sort of risk factors. And then we looked at we drew blood and looked at the Alaska Native population in the village. We looked at the teachers, and we found that the teachers' seropositivity was still very low. It was exactly what you'd expect from someone of that age in the lower 48. But as it turns out, when you go and spend time in the villages in Alaska and remote Alaska, teachers, they're based themselves at the school, and oftentimes the school is the only place that has running water and flush toilets. The teachers will live in a place, a small house on their own. They're not living under crowded living conditions. So we haven't really done a study to address that, but it's a great question. Yeah.
You're getting all the questions. So another question for you. Why did you, I might have missed this in your presentation, but what was the odds ratio for family history that triggered that was the only signal that you would look at to decide whether or not you tested for H. pylori? I kind of see the rationale for not testing everybody and treating because they have such a high reinfection rate, right? Mm-hmm. So I assume that played into the decision making, but it sounded like, you were only going to test patients who had a first-degree family history of gastric cancer.
Yeah, it's not really that. I mean, we're trying to limit our testing of Helicobacter pylori because it's so prevalent in the population, and we don't want to be treating everyone. It's just not going to be an effective strategy for us. So when patients come in,
so then, yeah, right. So then you're essentially bypassing primary prevention and kind of jumping to a secondary prevention strategy, right?
Right, exactly.
But it seems like that, to do reasonable secondary prevention, because the entire population is still at risk.
Sure, yeah.
Right? So, again, why not do something like an EGD at a certain age to further risk stratify that?
Right, it's a great question, and these are all things we're talking about and thinking about in Alaska, and we wanted to make a first step. We wanted to do a first step, and we wanted to add on those folks who have a relative, first-degree relative with gastric cancer, and treat them, and then expand and then do this screening program for them. We're in the process of reassessing those diagnosis and treatment guidelines in Alaska right now because of exactly the question that you're asking. So that actually came up with the expert panel in July also. So that's something that we're in the process of doing too. So it's a great question.
I'm just going to ask you to just comment a little bit, because when I went to Alaska and I went to this panel, it's pretty daunting what the challenges of taking care of people in Alaska. And I wanted to just ask you to just describe where people live and how they get medical care and how they access an EGD in Alaska.
Sure. So, the majority of Alaska Native persons live in rural Alaska. And rural Alaska, for those of you who've never been there, is extremely remote. There are no roads to these villages in rural Alaska. There's a very limited road system in the state. So to get to these villages, you either have to fly or you have to take a boat. So pretty much to get to these villages, you have to fly, which is incredibly expensive. So the Alaska Native Tribal Health Consortium and the tribal health organizations have set up a medical care system that's based on hub cities. So there are these sort of second world hub cities all over the state. There are tribal hospitals within these hub cities. Doctors live in these hub cities, and doctors are then affiliated with a group of villages in a region. And each village has a health aide and a health clinic. And so the health aide might have a high school education. They get trained intensively for a period of 2 weeks at the medical center, given sort of a cookbook on how to treat things. And then when patients come in, if they can't handle it, they'll call the doctor and they'll refer it to the doctor. So we probably do have higher rates of antimicrobial prescribing out in rural areas in Alaska. That's why, maybe in part why we have higher rates of resistance. But if you need to get an EGD, it's very, very difficult if you're living in a rural village. And so it's most people, most Alaskan Natives, we heard stories even at this forum, that people don't want to leave their village. They don't want to go into the big city, and it's the hub city. They don't want to be away from their family. They want to stay. And if they're having some symptoms and they don't know that those are alarm symptoms, they're just going to grin and bear it. And then they're going to come in at a late stage. So it's a real daunting issue. It's a great point, Julie.
All right.
All right, so yeah, why don't we wrap this up? Thank you to the panel.